Bacteriology review. Culture 24 hours, most definitive method for diagnosis and treatment of an infection. Sites tested determined by suspected site of infection, urine, blood, CSF, sputum, etc. Provides initial identification of organism by gram stain. A gram stain is used to classify bacteria into gram positive or gram negative based on the organism's ability to retain stain, either purple or blue or red, indicating the makeup of its cell wall. The staining also allows for visualization of the organism and morphology, bacilli, cocci, rods, etc. This is usually the first test performed on a culture of a potentially infectious site. It allows practitioners to streamline antibiotic therapy initially and empirically. It is essential to know organism morphology and what organisms are typically associated with infections at a given site. With this information, antibiotic selection can be made based on susceptibility location. We can achieve appropriate concentrations and patient factors. Growth on selective media, presence or absence of enzymes such as beta lactamase producing or chemical characteristics. Definitive identification of organism follows. Colonization versus infection. Colonization. Organisms do not invade the host but are part of the normal flora, microorganisms that normally reside at a given site. Example: the small and large intestine normal flora includes many organisms such as Lactobacillus, Streptococcus, Enterococcus, Enterobacteriaceae, Peptostreptococcus, bacteroids, or anaerobes. Their presence is expected, non-infectious, and serves a symbiotic relationship. Staphylococcus species are common skin flora and are not found in the normal flora of the GI tract, so its presence there would be pathogenic. The presence of large numbers of epithelial cells from the skin from a specific sample would indicate contamination of a sample. Infection. Organisms invade the host and patient has signs and symptoms of infectious process. Contamination. The isolated organisms came from the patient's skin or the environment and are inadvertently part of the collected sample. Virulence. The ability of an agent of infection to produce disease. The virulence of a microorganism is a measure of the severity of the disease it causes. Pathogenicity versus virulence. Pathogenicity refers to the ability of an organism to cause disease, i.e., harm the host. This ability represents a genetic component of the pathogen, and the overt damage done to the host is a property of the host-pathogen interactions. Commensals and opportunistic pathogens lack this inherent ability to cause disease. However, disease is not an inevitable outcome of the host-pathogen interaction, and furthermore, pathogens can express a wide range of virulence. Virulence, a term often used interchangeably with pathogenicity, refers to the degree of pathology caused by the organism. The extent of the virulence is usually correlated with the ability of the pathogen to multiply within the host and may be affected by other factors, i.e., conditional. In summary, organisms, species, or strain is defined as being pathogenic or not, and depending upon conditions may exhibit different levels of virulence. Sensitivity of organism to antimicrobial agent. MIC, lowest concentration of drug that will inhibit visible growth. MBC, lowest concentration of drug that fails to show growth or results in 99.9% reduction of the initial inoculum. Antibacterial combinations, synergy, greater activity of two agents combined than the sum of activity of either agent alone. Antagonism, activity that is worse or less effective than either agent alone. Additive or indifferent, activity that is neither synergistic or antagonistic. Post-antibiotic effect, persistent suppression of bacterial growth after brief exposure to the antibiotic. Time versus concentration dependent killing. Time-dependent killers. Killing is dependent on the time an organism is in contact with the drug. Concentration-dependent killers. Killing is dependent on the concentration of the drug that the organism is exposed to. Steps of bacterial infection. Bind to electrochemically complementary tissue. Colonize. Exponential growth. Produce toxins and enzymes. Mechanisms of bacterial resistance, the ability of a microbe to resist the effects of medication previously used to treat them, causing antibiotics to be ineffective. Porin channels adapt to prevent drug entry. Drug metabolizing enzymes, e.g. beta-lactases, ATP-driven P-glycoprotein efflux pumps, changes in drug-binding proteins, e.g. 4B-lactams, types of treatment, empiric, initial broad antimicrobial spectrum before identification of the organisms directed against the organisms known to cause the infection in question based on a patient's presentation. Definitive antimicrobial selected based on clear identification of the organisms and proven sensitivity of the organisms. Prophylactic antimicrobial directed against a single pathogen or multiple pathogens to prevent an infection from occurring, usually short-term before surgery. Dental procedures that can be long-term, such as AIDS. Please be very familiar with the respiratory infections that were emphasized in the threads, readings, and study guides. So CAP, aspiration pneumonia, AON, ABRS, and common cold, as well as familiarity with management, symptom management. Table 75-6. Things to consider are causative organism, risk factor for infection, risk factors for MDR, treatment, consideration of the whole patient when selecting among the possible alternative possibilities, drug interactions, adverse effects, and patient education. You do not have to memorize dosages. Aspiration. Most pneumonia arises following the aspiration of microorganisms from the oral cavity or nasopharynx. The term aspiration pneumonia should be reserved for pneumonitis resulting from the altered clearances. There are usually two requirements to produce aspiration pneumonia: compromise in the usual defenses that protect the lower airways, including glottic closure, cough reflex, and other clearing mechanisms, and inoculum, deleterious to the lower airways by a direct toxic effect, such as gastric acid, stimulation of an inflammatory process from bacterial infection, or obstruction due to uncleared fluid or particulate matter. The pathogens that commonly produce pneumonia, such as Streptococcus pneumoniae, Haemophilus influenzae, gram-negative bacilli, and Staphylococcus aureus, are relatively virulent bacteria, so that only a small inoculum is required and the aspiration is usually subtle. A true aspiration pneumonia by convention usually refers to an infection caused by less virulent bacteria, primarily anaerobes, which are common constituents of the normal flora in a susceptible host prone to aspiration. Several risk factors, some we have discussed, i.e. acid suppression, reduced consciousness resulting in a compromise of the cough reflex and glottic closure that is most commonly seen with alcohol or illicit drug abuse or anesthesia, and also occurs with generalized seizures. Dysphagia from neurologic deficits, disorders of the upper gastrointestinal tract, including esophageal disease, surgery involving the upper airways or esophagus, and gastric reflux. Mechanical disruption of the glottic closure or cardiac sphincter due to tracheostomy, endotracheal intubation, bronchoscopy, upper endoscopy, and nasogastric feeding. Pharyngeal anesthesia and miscellaneous conditions such as protracated vomiting, large volume tube feedings, feeding gastronomy, the recumbent position, and drowning. Other potential risk factors: increasing age, male sex, smoking, diabetes mellitus, recurrent vomiting, oropharyngeal colonization, poor oral hygiene. Use of medications such as H2 receptor antagonists or proton pump inhibitors may alter gastric pH, allowing growth of potentially pathogenic organisms within gastric aspiration, such that if aspiration occurs, it will more likely be infectious in nature. A number of interventions, i.e. positioning, dietary changes, drugs, oral hygiene, tube feedings, have been proposed to prevent aspiration, especially in older patients and stroke patients. Treatment. For community-acquired aspiration pneumonia, consider treatment for both streptococci and anaerobes. Options include dosing for adults with normal renal function, clindamycin 300 milligrams orally 4 times daily or 600 milligrams IV every 8 hours, beta-lactam, beta-lactamase inhibitors such as amoxicillin, clavulante 875 milligrams orally twice daily, or ampicillin sulbactam 1.5 to 3 grams IV every 6 hours. For hospital-acquired aspiration pneumonia, treatment should be based on suspected pathogens. Options with anaerobic coverage include dosing for adults with normal renal function, piperacillin, tazobactam 4.5 grams every 6 hours, or ampicillin sulbactam 1.5 grams, 1 gram ampicillin and 0.5 grams sulbactam to 3 grams, 2 grams ampicillin, 1 gram sulbactam every 6 hours, and anti-pseudomodal carbapenem such as meropenem 1 gram every 8 hours, and anti-pseudomonal cephalosporin such as cefdipine 1 to 2 grams every 8 to 12 hours, or ceftazidime 1 gram every 8 to 12 hours, plus metronidazole 500 milligrams IV every 8 hours, or clindamycin 600 milligrams 2.7 grams IV daily. in 2 to 4 equally divided doses, plus consideration of vancomycin 15 milligrams per kilogram every 12 hours, adjusted to troughs of 15 to 20 micrograms per milliliter, or linezolid if MRSA is suspect. Note, empiric therapy for community-acquired anaerobic mixed lung infection, often referred to as imprecisely as aspiration pneumonia. Gram stain of sputum shows numerous polys and mixed oral flora. A continuum of acute to subacute to chronic, typically oral flora, infection, necrotizing pneumonia, lung abscesses, and empyema. Predisposing conditions, neurologic deficits, reduced level of consciousness, esophageal motility disorders, endotracheal intubation, endoscopy, protracated or large volume vomiting, and intoxication. Distinct from acute aspiration event, i.e. aspiration pneumonitis. Aspiration pneumonitis is an acute chemical lung injury caused by aspiration and or inhalation of sterile acidic gastric content. Can proceed to severe lung injury and respiratory failure at risk of secondary bacterial infection, estimated at 25%. In retrospective study, no improvement outcome for patients who received prophylactic antimicrobial therapy compared to those who did not. More frequent escalation of therapy in prophylaxis groups. Coverage for anaerobes not routinely recommended unless lung abscess or empyema is suspected. Although reasonable if anaerobic infection is suspected on clinical grounds, such as subacute to chronic clinical course, presence of periodontal disease, foul-smelling sputum, high-quality sputum gram stain that shows numerous polys, and mixed or oral type flora. Can switch to oral therapy once the patient has responded clinically. Optimal duration of therapy unknown, but 7 to 10 days in patients with pneumonia without empyema or lung abscesses. 4 to 6 weeks for empyema or lung abscesses, guided by radiographic resolution of the abscess and adequacy of drainage. Patients who defervesce rapidly should get repeated imaging. If infiltrates and signs and symptoms have resolved, antibiotics should be discontinued as it is likely aspiration pneumonitis and not aspiration pneumonia. Community-acquired pneumonia. An acute infection of the pulmonary parenchyma in a patient who has acquired infection in the community. Pathogens. Viral pathogens responsible for 18 to 39% of cases. Bacterial. Most common etiology for CAP is the typical pathogen is Streptococcus pneumoniae, Mora exhala catarrhalis, Haemophilus influenzae, most common cause. Risk factors for development of CAP: current or former smoking, consumption of greater than 80 grams of alcohol per day or history of alcohol abuse, underweight, household size greater than 10 individuals, regular contact with children, frequent visits to general practitioner. Incidence of CAP may be higher in patients taking PPIs than in patients not taking PPIs. Risk factors for development of MDR pneumonia age greater than 65 years, beta-lactam macrolide or fluoroquinolone therapy within the past 3 to 6 months, alcoholism, medical comorbidities, immunosuppressive illness or therapy, exposure to a child in a daycare center. Antibiotic therapy is typically begun on an empiric basis since the causative organism is not identified in an appreciable proportion of patients. Note situations where double coverage is warranted. Adult outpatient without comorbidities, no antibiotics in the past 3 months, amoxicillin high dose. Doxycycline or macrolides of local rates of macrolide-resistant strep pneumoniae are greater than 25%. Adult outpatient with comorbidities or AB use in the past 3 months, respiratory quinolone such as levofloxacin, moxifloxacin, or beta-lactam antibiotic, so amoxil plus CLV, so like augmented, or cefuroxamine or cefdinir or cefpodoxime plus macrolide, so such as azithromycin or clarithromycin, or beta-lactam antibiotic, so such as cefuroxime, cefdinir, or cefpoxidime, and then of course the amoxil CLV combo, plus doxycycline. Comorbidities of concern: alcoholism, strep pneumoniae, H. influenzae, COPD, H. influenzae, strep pneumoniae, post-CVA aspiration, oral flora strep pneumoniae, post-obstruction of bronchi, strep pneumoniae anaerobes, post-influenza, strep pneumoniae staph aureus, neutropenia, immunocompromised host, Pseudomonas aeruginosa, injection of drug use, staph aureus, MRSA, and MSSA. Adult inpatient, not ICU, respiratory quinolone, so levofloxacin, monofloxacin, or third generation cephalosporin, or Erapitem plus macrolide or doxy. Adult inpatient ICU, no Pseudomonas, third generation cephalosporins plus azithromycin or respiratory quinolone. Adult inpatient ICU, Pseudomonas, cefepime or ceftazidime, or piperacillin tazobactam, or imipenem or meropenem plus quinolone or AMG. If AMG, add azithromycin or quinolone. If CA MRSA is concerned, add vancomycin or linezolid if susceptible. Clindamycin to above. Table 74-2. I'll go back and do a video of the tables. Vaccinations. In 2021, 2 new pneumococcal vaccines, 15 and 20 valent conjugate vaccines, PCV were approved by the U.S. Food and Drug Administration, with the addition of 2 to 7 serotypes covered by PCV 15 and PCV 20, respectively. These new vaccines will cover an estimated 42 to 65% of causes of invasive pneumococcal disease, which is 15 to 35% more than PCV 13. Accordingly, the Advisory Committee of Immunization Practices, ACIP, adjusted and simplified recommendations for pneumococcal vaccine in adults in late 2021 to reflect these changes in available vaccinations. In the updated Centers for Disease Control and Prevention immunization schedule, all eligible patients are now recommended to receive either a single dose of PCV 20 or a dose of PCV 15 followed by a dose of the 23-valent pneumococcal polysaccharide vaccine, PPSV 23. CDC recommends annual influenza vaccination for everyone 6 months and older with any licensed age-appropriate flu vaccine, 7 RIV4 or LAIV4, with no preference expressed for any one of the vaccine over another. And then COVID vaccination. Upper respiratory tract infections. For most people, colds are viral and symptoms are self-limited. Table 75-6. So again, I'll do a video of the tables. OTCs, analgesic, antipyretic, saline, nasal irrigation, nasal glucocorticoids, oral nasal decongestants, mucolytics, antihistamines, etc. Indications, precautions, drug-to-drug interactions. Otitis media, risk factors, pacifier use, lack of breastfeeding, tobacco smoke exposure, contact with other children, family history of otitis media, GERD, allergies, cleft palate, immunodeficiency. Pathogens, and that is a table 75-1. Pathogens. S. pneumoniae is the most important bacterial cause of acute otitis media, but it can include others such as H. influenzae and M. catarrhalis. It is important to make accurate diagnosis of acute otitis media to avoid the inappropriate use of antibiotics and the associated increase in antibiotic resistance rates. The choice of strategy depends on the age of the child, the severity of illness, and parental preference. If observation option is used, mechanism must be put in place to ensure follow-up and begin antibiotic therapy if the child worsens or fails to improve within 48 to 72 hours of onset of symptoms. When decision to treat acute otitis media with antibiotics has been made, reassess patient if caregiver reports symptoms have worsened or failed to respond to initial antibiotic therapy within 48 to 72 hours. So, summary: penicillin allergy, no. Risk factors for resistance, no. Then amoxicillin, yes. Then amoxicillin clavulante. If there is a penicillin reaction, anaphylaxis reaction, no. Then cefdinir, ceftriaxone, cefuroxamine, or cefoxamine. If the answer is yes, then you use clindamycin. Amoxicillin is the drug of choice for most patients. High dose amoxicillin. Amoxicillin recommended if the child has not received amoxicillin in the past 30 days. Dose does not have concurrent purulent conjunctivitis and is not allergic to penicillin. Amox and clavulante combo, so augmentin or such, antibiotic with additional beta lactamase coverage, amoxicillin clavulante, is recommended if the child has received amoxicillin in the past 30 days, has concurrent purulent conjunctivitis, or has a history of recurrent AON unresponsive to amoxicillin. Cefuroxime, cefpodoxamine, or cefdinir, 14 milligrams per kilogram for a child. Reasonable with mild hypersensitivity reactions, mild delayed hypersensitivity reactions type 2 or 4 to penicillin appear after more than one dose, typically after days of treatment. They lack features of immunoglobulin E, IgE mediated reaction, such as anaphylaxis, angioedema, bronchospasm, urticaria, and serious life-threatening delayed drug reactions. Alternate is macrolide and clindamycin, reasonable alternatives with anaphylaxis or IgE-mediated reaction to penicillin or cephalosporin. Immediate reactions type 1 to penicillin classically begin within 1 hour of the initial or last administered dose and have features of IgE-mediated reaction such as anaphylaxis, angioedema, bronchospasm, urticaria, or serious delayed reactions. Adjunctive therapies, pain management. Pain is a common feature of AOM and may be severe. Treatment to reduce ear pain in children with AOM, whether or not they are treated with antibiotics, is recommended. Oral analgesics such as acetaminophen or ibuprofen. Topical anesthetics, most if not all, have been withdrawn from the market in the United States because they have not been evaluated by the U.S. Food and Drug Administration for safety, effectiveness, and quality. Decongestants and antihistamine studies suggest lack of benefit and a potential for delayed resolution of middle ear fluid. External application of heat or cold, installation of olive oil, herbal extracts. Clinical conclusions regarding use is limited due to lack of supporting evidence. Vaccines, prevention, vaccinations, influenza, pneumococcal conjugate, so PCV 13, first dose at 2 months, second dose at 4 months, third dose at 6 months, fourth dose at 12 to 15 months, and then influenza annual vaccination. Antibiotic prophylaxis is not recommended. Acute rhinosinusitis, ARS, is defined as symptomatic inflammation of the nasal cavity and paranasal sinuses lasting less than 4 weeks. The term rhinosinusitis is preferred to sinusitis since inflammation of the sinuses rarely occurs without concurrent inflammation of the nasal mucosa. Risk factor for ARBS. anatomic defects, nasogastric tubes, immunodeficiency, traumatic head injury, allergic, non-allergic rhinitis, dental infections or procedures, aspiration, allergy, nasal polyps and asthma, cystic fibrosis or ciliary dyskinesia, swimming or diving, intranasal medications, mechanical ventilation, tobacco smoke exposure, viral respiratory tract infection or winter season, GERD, female sex, nasogastric tubes. In addition to supportive care options for the outpatient management of uncomplicated acute bacterial rhinosinusitis or ABRS, are observation or antibiotics depending on patient follow-up. ABRS may be a self-limited disease and patients may improve without antibiotic therapy. The typical pathogens, Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. Treatment. Do they have a penicillin allergy? No. Are there risk factors for resistance? No. Low dose amoxicillin? Yes. High dose amoxicillin clavulante? Yes to a penicillin allergy. Adults, respiratory, fluoroquinolone and doxycycline. Children, levofloxacin, clindamycin plus cefixime, linezolid plus cefixime, monotherapy with cefdinir, cefpodoxime, or cefuroxime. Preferred no risk of resistance or children, mild to moderate diagnosis, STD, dose amoxicillin plus clavulante. Preferred risk of resistance 3 or children severe diagnosis, high dose amoxicillin clavulante. Alternate adult respiratory quinolone, doxy, or clindamycin plus cefixime or cefpodoxime. Alternate child, cefpodoxime, cefdinir, or levofloxacin. Macrolides, SMZ-TMP, and second or third generation cephalosporins are not recommended for empiric therapy because of high rates of resistance of S. pneumoniae and of H. influenzae for trimethoprim sulfamethoxazole. Note that the alternative in a child does not include doxycycline, and we know why. Systemically administered fluoroquinolones are not recommended for routine use in children less than 18 years of age because studies in immature animals have demonstrated the development of arthropathy with erosions of the cartilage in weight-bearing joints. Please note that tetracyclines like doxycycline should not be used in children. The use of drugs of the tetracycline class during tooth development, the last half of pregnancy, infancy, and childhood to the age of 8 years may cause permanent discoloration of the teeth, yellow, gray, brown. Pharyngitis. Inflammation of the throat often caused by infection, generally self-limiting and resolves in a few days without antibiotics. Typical pathogens, often viral, self-limiting, Streptococcus pyogenes, group A streptococci. Treatment for adults at higher risk for severe infections, such as poorly controlled diabetes mellitus, immunocompromised on chronic corticosteroids. Throat culture can be obtained at the initial visit, even if the rapid antigen detection test is negative for gas. Treatment: penicillin V, amoxicillin, benzathine penicillin G times 1 intramuscular dose. Common cold: analgesics, antipyretics, so acetaminophen, ibuprofen, decongestants, phenylephrine, systemic pseudoephedrine, cough suppressants, expectorants, anticholinergics. Final considerations: patient allergies, penicillin or sulfa allergies, drug interactions, age restrictions, so quinolones and tetracyclines, adverse effects, clindamycin, AAD, C. diff, diarrhea, pregnancy. The antibiotics overview. Brief drug summary for a few of the antibiotics we mentioned. More detailed document attached for your convenience. Amoxicillin. Actually, I'm going to do this on a new thing.